JP is going to be giving us a talk on shock, and then we've got an extended house staff meeting with Ken a little bit later this morning. But before JP starts, I want to welcome Dr. Mukherjee, who's going to give an announcement to the group. So thanks for being here this morning.
Great, thanks, Courtney. My name's Sean Mukherjee. I direct our academic hospital medicine fellowship, so happy to be here for the next hour to talk to you about that. Courtney did not smile when I said that. I'm going to be less than a minute here. I just wanted to raise some awareness about this fellowship. I'm an academic hospitalist at UW Medical Center. I graduated residency in 2007, and the next year I was a hospitalist at UW. And for a year, I tried to be academic, but I didn't really know what that meant or how to do it. Kind of spun my wheels on projects, learning basics of how to get something done. And the following year, I went to UCSF and did a one-year hospital medicine fellowship. And it really gave me some core skills in how to be scholarly, how to do a project, how to get things done, how to kind of understand what was important and authentic to me in my career. So we're trying to offer the same thing here at UW. Since 2018, we have this fellowship. You can see some of the details in the slide. I won't read all the bullet points out loud to you, but you can kind of get an idea of what we're trying to do. The goal is to help you, if you're interested in being an academic hospital medicine, to kind of realize that goal in a way that's really authentic to you and helps you have an impactful career moving forward. So if you're interested, please give me an email. I'm happy to talk, even if it's not the right fit for you. Happy to talk about what might lie ahead for you in the future and whether the fellowship's a good fit. And that's all I had. I'm not going to take any questions. Thank you so much for this opportunity. And in the chat, I pasted the flyer, so feel free to take a look at that. Thanks, Courtney.
Of course, thank you so much for being here. If you want to maybe put the flyer again in the chat, just for people who joined after you put it in so that people have access for it. But thank you so much for joining. And now I will turn things over to JP. Take it away.
Fantastic. Let me share my screen. All right. Does everyone see that? Perfect. Everyone can hear me? Double thumbs up from Courtney. Thank you very much. All right. So my name is Jean-Paul Toussaint. I'm one of the residents in my last year of our fantastic program, and I'm going to talk a little bit about shock today. I'm going to try to keep this pretty simple, so bear with me. There's a lot of other more fantastic talks out there, but I think this is a good place to start for all of us. So I have no financial disclosures, probably not unsurprisingly. And I got some help from Janelle Badulak, one of the fantastic critical care doctors. I kind of started out actually from a presentation she did last fall, and you'll see some of her slides in here, and I did that purposely so that when you get additional presentations from some of our critical care faculty, you'll see similar things being said throughout. I also talked to Shri and Ariel, who I was on geriatrics with, to kind of get their insights into what might be helpful for all of us to know going forward. So we have some objectives for the talk today. First is that shock is a life-threatening multi-organ system failure that demands prompt attention. I would say for us, we're going to break down shock into 3 different types today. I think keeping a simplified approach is the best for us to begin with. So we'll break those down into hypovolemic, cardiogenic, and distributive processes. And I always like to think pump, pipe, tanks, just to keep it simple, to keep a schema together. And I encourage you to find your own schema to work through shock. And really the most important thing about shock is identifying the causing mechanism early, and then trying to understand if a patient's going to be fluid responsive, and that's what we'll spend a good chunk talking about today, is trying to figure out early if a patient is going to be fluid responsive or not. Or really the question is, if I give this patient fluids, is that going to be a danger to them? And then kind of following up on your approach to make sure that you're meeting the right goals, such as the lactate's improving, the blood pressure is improving, that you're seeing resolution of end organ damage. And I just put this forward because I did quite a bit of reading for this presentation today, and I actually thought this was kind of the best schema that I tend to think through. And I put this forward and I put it at the end of the presentation just so that we all have something that's readily available. If you were to take anything from this presentation today and put it in your back pocket, this might be a good slide to do that with. And the thing I like about this is this doesn't demand ultrasound mastery to be able to kind of understand shock. And that's kind of what I want to point out today, is that you don't have to be an ultrasound wizard to approach shock. And sometimes I think a lot of our presentations are kind of established from that standpoint. We have amazing critical care staff, and they're really great with ultrasound. But unfortunately, in our residency program, we don't always get enough experience to be proficient in the spot. So I think of approaching it in a different manner without using or relying on ultrasound is good. And I think this is a good way to begin. All right, so shock, starting out, we need to talk about what it is. What is shock? It's really inadequate perfusion at a cellular level. We think of it globally, kind of at the organ level, lack of perfusion, but really it's the cellular level. And what's happening is the mitochondria are just not getting enough oxygen, and they can't perform their job. And oxygen delivery is what it's about, and maintaining the adequate perfusion. So that will be our definition of shock today, and we'll talk about looking for evidence of that. Why do we care about shock? Why do we care about hypoxia, or the inadequate supply of oxygen to the tissues? It's associated with a really high mortality rate. These patients do exceptionally poor. Organs just don't do well without oxygen. And the quicker we address the inciting event, the more likely these patients are going to leave the hospital and do well and get back to their loved ones. And so that's why it's so important. So success in surviving shock, or our patient's survival of shock, is kind of having a simplified algorithm so that you can act quickly, and then hypothesis testing and follow up on treatment response. Don't overcomplicate it, keep it simple. And again, I'll just reiterate that I think the most important things in keeping it simple is trying to figure out the most likely cause and whether that patient is going to be fluid responsive or not. All right, so I already kind of mentioned these points, that we need to reduce mortality by early goal-directed therapy, and then kind of figure out what is the most likely cause. And again, I bring up this question of what is the chance that giving this patient fluids is likely to harm them? And I think that when you get called to the bedside for a hypotensive patient, this is often one of the first things we're thinking about, is what is the most likely cause, and are fluids going to hurt this patient? All right, and here I like this slide, because really when we're called to the bedside, oftentimes we're called when shock is compensated. So this is a slide from the CDC's kind of one of their educational algorithms, and the part I want you to focus on is in the middle, the compensated shock. And we have evidence of stable circulation on the left, and then hypotensive shock. And really, the earlier we can address shock when it's in its compensated form, the better patients are going to do. And we have tons of different tools like QSOFA, SIRS criteria, that try to help us identify patients that are at risk of progressing into shock. And these often are trying to identify patients that are in compensated shock. And then we see here that compensated shock has things, for example, poor capillary refill, as the body is trying to vasoconstrict in our peripheries and shunt that blood to our vital organs. All right, so definitions of shock. There's multiple different types, but let's start with kind of some basic ones. I already kind of approached the compensated shock. So compensated shock is when we really don't have a lot of evidence for shock. Decompensated shock, that's more of what we think of when we're coming to the bedside for a hypotensive patient, for a patient with obvious end organ damage. And then there's refractory shock. And the idea of refractory shock is, well, given that there's this compensatory reserve, patients can only, or the physiology can only apply so much to support them as the processes devolve. But there's lots of other definitions. I mean, we already talked about hypoxia, and I think that's the best one because that's at a cellular and metabolic level. And really we could see this at a histological level too. And what happens when you end up in these hypoxic states is that you end up having leaky cellular membranes, and you get a lot of edema in these tissues too. And that also disrupts the ability for oxygen to be provided. So it's kind of this vicious cycle. And that's why we think of this refractory shock as once vital organs such as the heart experiences profound hypoxia, then it really doesn't have the reserve to be able to complete its function. And then the most important is these clinical definitions, because these are the definitions that we're ultimately relying on at the bedside. And this is what we'll be addressing. And I just think that, you know, the best definitions are, for example, the International Sepsis Committee or Surviving Sepsis Campaign. These have done a lot to try to identify septic shock early, as it has the highest mortality rate. Cardiogenic is another, and that's just because cardiology has fantastic studies and they do a great job defining their cohorts. All right, so the most common type of shock, the one that we really need to try to figure out the earliest, is hypovolemic shock, or just a lack of adequate volume for our patient's heart to be able to perfuse their organs. So the contributors to this are bleeding, third spacing, vomiting, diarrhea, urination, and environmental losses or functional losses. And often those are in our patients that can't drink for themselves, that are in bed, altered mental status. Really, these present themselves when we go to the bedside more than anything else. Cardiogenic shock, I mean, this is end organ damage from lack of perfusion related to pump failure, and there can be multiple contributors to pump failure. That can be arrhythmias, valvular, or poor contractility. MIs are one of the leading cause of cardiogenic shock, so it's something that we should think about and identify early as well. And I often think, you know, we need to identify hypovolemic, we need to identify sepsis, we need to identify cardiogenic shock as early as we can, and those are kind of the three things that I think of first. So this is why we have cardiogenic shock as our second slide here on shock definitions. I also like to lump other obstructive causes, whether it's outflow obstruction or inflow obstruction, into the cardiogenic shock. I just think it's a little easier to work with initially for us. So we'll lump in things like pneumothorax or pulmonary embolism, tamponade. And I mentioned already valvular problems, and I think it's easier to lump those. Don't forget them. So cardiogenic shock definitions, I mentioned that, man, cardiology has some amazing trials, and so I look to them to try to define for us where our shock definition would be. And really, we're seeing a systolic blood pressure less than 90, sometimes MAP less than 70, but all these have evidence of end organ damage. The other thing I kind of want to identify for you is that a lot of these definitions are acknowledging that the patients need to be appropriately fluid resuscitated. You need to try to approach euvolemia as best we can. And so here we are again trying to say, man, is this patient going to be fluid responsive? Before we call any other type of shock, we need to ask ourselves, does this patient have adequate volume? All right, if it's not cardiogenic or it's hypovolemic shock, it's that third bucket of distributive shock. And this is a lump bucket of kind of the hyperinflammatory state, whether it's pancreatitis, which is a kind of a Sears systemic inflammatory response, or anaphylaxis. Neurogenic is just really, this is the pipe problem where we just lose. We have vasoplegia. There's sepsis, which also is similar. That's due to immune mediators. And then there's hepatic failure and adrenal insufficiency. Really, the most important within the distributive shock I think of is don't miss septic shock, right? There's the Surviving Sepsis Campaign, and the reason why we try for early goal-directed therapy of fluids and antibiotics. And so in the distributive shock bucket, I always really put sepsis at the top, and I think you should too. All right, and sepsis has a definition. Septic shock has a really high mortality rate, somewhere around 40%. And really it's end organ damage related to dysregulated host response. And if you have a patient on a pressor and you have a source of infection, that is septic shock. And again, the definition has absence of hypovolemia. So we're seeing again and again and again that we really need to make sure that our patient is adequately fluid resuscitated or euvolemic. And then I put in the Q-SOFA here. We remember the SIRS criteria. The Q-SOFA is just a more sensitive test to try to identify early if our patients are progressing towards shock. And I just want to identify the difference between the Q-SOFA, or at least one of the biggest differences between the Q-SOFA and the SIRS criteria is including that systolic blood pressure. If you recall, the SIRS criteria did not include the systolic blood pressure, so you could meet SIRS criteria without being hypotensive. Whereas the Q-SOFA, that lumps that systolic blood pressure. You only need 2 of them. So altered mental status or respiratory rate greater than 22 can lead you into that group. And there's other things that are involved with that as well. All right, so I'm just going to do a little plug. So I'm part of the sepsis committee. And so I ask that if you are concerned about sepsis in your pre-shock or hypotensive patient, please use the Sepsis SOS power plan. There's a lot of reasons for that, part of which it'll help you guide your antibiotic selection. It'll also help guide fluid administration, and it'll help you trend the lactate. And then really another thing I'm going to put a plug is, as we are seeing more and more obese patients, just acknowledging that giving the 30 cc per kilogram that's recommended should be likely based on ideal body weight. You're just going to give patients such massive amount of fluids, and now we're starting to understand that maybe less is more when it comes to fluids, as our patients can remain in the ICU on ventilators requiring additional days of diuresis if we give them too much. And I think that's an important thing to acknowledge. And the other thing about sepsis, if you suspect it, do a broad infectious workup. Don't forget to get your cultures before you start your antimicrobials. And then I just pitched that, we live in an amazing time where we're addressing this #1 cause of mortality in the world. And there's campaigns such as the Surviving Sepsis campaign that have done a lot to benefit our patients so that we can address this early and they can have better outcomes and go home to their loved ones. All right, so here's some important equations that have come up on almost every shock presentation that I personally have seen. So we're going to kind of review the perfusion pressure, oxygen delivery, and cardiac output, and what those kind of mean. I get a little frustrated with these equations sometimes. I think they're good to think about more in the classroom and less at the bedside. And as far as the perfusion pressure, again, I kind of at the beginning mentioned that I like to simplify it into a pump type tank. And here I think perfusion pressure is again kind of broken down into that. And I got this PowerPoint slide, which I modified a little bit from Janelle. And so we see that the mean arterial pressure is related to the systemic vascular resistance times the cardiac output, Q. And then plus our CVP. This equation frustrates me a little because it's not a true equation. This is not like ideal. This is made up. This is a model of how we think things work, and it allows us to follow. But you'll come across this from when we're trying to figure out cardiac output. It can be difficult. So, for example, the systemic vascular resistance can be difficult to know what it is exactly. And really, I think our bedside exam is better for thinking about these things than necessarily any one equation. But just acknowledging that our cardiac output is the heart rate times stroke volume. And it's important to think about this when you're trying to gauge whether a patient is fluid responsive or not, because when we give them fluids, what we actually want to see is improvement in their cardiac output. And we can see here that there's multiple things that influence the mean arterial pressure or perfusing pressure. So sometimes we can improve our cardiac output, but we don't actually see improvements in our blood pressure. And I think it's just important to acknowledge that when we're looking at this equation, because as I went through the data on fluid responsiveness, sometimes it's frustrating because you won't always see an increase in the MAP or your perfusion pressures. You might have other factors such as your resistance that are diminishing what you're seeing. So that's just something to acknowledge, and I think this equation helps with that. Oxygen delivery. So this equation is also, or this slide is also by Janelle. And this one, I think the importance of this slide is, hey, you know what? Remember this equation. You got to have the right cardiac output. You got to have the right hemoglobin. You have to have the right oxygen saturation. So don't forget about these things. Address hypoxemia, okay, and address anemia. So don't forget to address anemia. That's one of the big important things about that. And again, we try to augment cardiac output. All right, so I'm going to go through a case here. We're doing pretty good. We're 20 minutes in. So our first case, 72-year-old gentleman with a history of BPH, type 2 diabetes, coronary artery disease, dementia, presented after a ground level fall resulting in a femoral shaft fracture. And he's now status post intermedullary now. You get a page, you just got Jerry sign out, kind of walking back to the team room. You get paged, an FYI by the stat nurse, which is always nice, that your patient's blood pressure is 72 or 44. But don't worry, people are at the bedside, just not you. So does this patient have shock? Would someone love to chime in whether they think?
How much fluid have they got?
Yes, so they haven't got any fluid yet.
Then I don't know.
So I think you kind of are already answering what we may want to do. We may want to consider whether this patient would be appropriate for a little fluids. I'd say that this patient, likely has shock with that blood pressure. We need to go to the bedside and look for evidence of end organ damage, but I'm worried that this patient is kind of progressing and decompensated. Maybe they're in that compensatory shock and now their compensatory reserve is not able to sustain whatever they're experiencing right now. So I'm worried that this patient could be developing shock. So what's our first steps in evaluating a patient? Let's go to the bedside, examine the patient. What are we specifically looking for? We're trying to find the cause of why that patient is hypotensive or progressing in shock, and trying to answer the question of, is it safe to give this patient fluids? Do we need to consider other ways to test whether they're going to be fluid responsive or not? And one thing I just want to bring up now, because I thought it was important to include in this slide, is when do you want to call the ICU? What is our level of comfort? I mean, because we're on this both sides, right? Sometimes we're on the acute care floor and sometimes we're in the ICU. And I just want to put in a little bit, open up the space to hear what thoughts are from other residents about when do you call the ICU for your hypotensive patients?
If you feel like you don't have the resources on the floor to try and immediately stabilize them. Or if the nursing staff, the patient needs more frequent monitoring, things like that.
I think a key question is always like, is there anything you're going to be able to do immediately right now to reverse the process? And how concerned are you that they're going to immediately continue to devolve and become more ill? Those are two questions in my mind.
Yeah, I think that both of you raised very good points. And oftentimes we have our amazing stat nurses at the bedside with us because a rapid response has been called. And I like to just be open with them and tell them, hey, set a game plan, where we kind of acknowledge where the patient is at and we say, okay, we're going to try these things. And if these things don't cause this patient to improve, then the next step would be the ICU. And oftentimes it's giving some fluids. And if we're not seeing improvement with fluids, or we do assessment of fluid responsiveness and we're not seeing that that's likely to be the case, then that suggests we may need to start pressors or something else that we can't deal with on the acute care floor. And so I like to rely on our stat nurse. And really another threshold for me is if I've given a patient 2 liters of fluid, which is quite a bit of fluid, and they're still hypotensive, man, that patient should likely be started on pressors and going to the ICU. And that's just an arbitrary number. And sometimes for some patients it's less, right? And all depends on their volume status. If they're volume overloaded and they're hypotensive, I mean, that patient needs to go directly to the ICU. And so it really depends on what you can offer them at the floor that you're on. So I think that was all great. And I just also want to say that it's where your comfort level is too. So if you're ever on the floor and you're dealing with a patient and you don't feel comfortable, reach out to your colleagues. I mean, given that we work together and it's usually our colleagues in ICU, reach out to them. Let them know that you're concerned. Let them know that you can use some support. It doesn't necessarily mean the patient's going to get to the ICU. It might just mean that you're going to get somebody to come and kind of provide support or assistance thinking through. All right. So signs and symptoms of shock. This is what we're doing at the bedside, right? We're looking at the blood pressure. That's only part of it though. And we're seeing, do they have altered mental status? How is their capillary refill? they have skin mottling? Are they having chest pain? How's their urine output? These are all things that we consider when we go to the bedside. And then we have some bedside tools, right? We have touching the patient, examining them. The most important things is looking, right, for volume overload, looking to feel the patient. Do they feel hot? Do we think that we're concerned for sepsis? Does the patient have a fever? Or does the patient feel cold? Does it feel like, you know, their heart is not putting out enough volume to produce their extremities, that their body is vasoconstricting their peripheries and their peripheries are cold? So, you know, cold peripheries, that can be associated with hypovolemic shock and cardiogenic shock. And so really just touching the patient and examining them is one of the most important things that we can do when we're called to the bedside. Other thing is just looking at their vital signs, right? This is something that we're trending. When you go to the bedside, you're gonna have them repeat the vitals. You're gonna have a measure of blood pressure in another arm. You're gonna look at that arterial line tracing and make sure it looks real. You're just gonna make sure that you have good data to make decisions from. And then if you happen to feel comfortable with an ultrasound probe and you have the time, then go ahead and do that. The only way you'll get better, the only way any of us will get better, is by trying to use these technologies, right? And it's becoming more and more of a thing. Oftentimes, when you're initially called to the bedside by the stat nurse, you often can't just leave to go grab the ultrasound. That's kind of frowned upon. You kind of have to give some suggestion that we should try this, and then I'll be back. So that's just kind of something to consider. But encourage you to try the ultrasound. You don't have to be a superstar with the ultrasound. All right, so shock, this is one slide again by Janelle, and this is kind of thinking through, hey, is this more of problems going on in the vessels, in the pipes with a low resistance, or are we having low cardiac output? And low cardiac output, as I mentioned before, is related to either hypovolemic or cardiogenic shock. And so these buckets break down, and oftentimes if you're using the ultrasound at the bedside, you can look at the IVC and try to get an idea of, do I think this is something from hypovolemic, or do I think this is cardiogenic? You can go from there, but really, this is a great slide, but it's not how I think through. I just want to present this slide again. This is more of how I think through. I tend not to grab an ultrasound probe until if there's not an obvious answer. If we have tried some things, if we have given some fluids, initially thinking that it's safe, and we're not making progress, that's when I think getting the ultrasound probe is the most helpful. Not necessarily in the initial evaluation, not all the time at least. All right, so the biggest thing in diagnosis and management of shock is assess and address effective circulating volume. Again, I'm reiterating that we need to figure out whether it's safe to trial our patients on some fluids. All right, and then we're treating vasodilation. And so really, if you have fluids going in and the patient is still hypotensive, right, that'd be starting a pressor. And the pressor of choice, whether it's distributive or cardiogenic shock, initially, it's not the wrong choice to pick norepinephrine. If you just don't know what's going on, a good pressor is norepinephrine to start. If you have obvious cardiogenic shock, right, dobutamine is not a wrong choice. That definitely helps. It's a better ionotrope. But if you just don't know, don't forget norepinephrine is a good place to start. All right, and then augmenting pump failure. All right, so when we're there at the bedside, we've done our exam, there's always additional data that we can get, and that's in the form of laboratory testing, right? And additional things like chest radiographs and ECGs. And really, you're gonna curtail your studies based on what you think going on, but it's never wrong to get a lactate in a hypotensive patient. I encourage you to do that because that's something that you can trend, and it's easier to direct your therapies based on reimbursement for the hospital. So it's even more important, even though reimbursements shouldn't drive what we do, but that's also another nice thing about the Sepsis SOS Power Plan. Might want to look at renal function. That's another very important thing in CVC. And then if we're thinking potential cardiogenic shock, eating cardiac enzymes, and then if, again, reiterating that if you think it's related to an infectious source, if you think you have sepsis going on, don't forget to get blood cultures, get your infectious workup going from there. Then you can always think of a mixed venous if you're worried about cardiogenic shock. It can be difficult to interpret though, I will warn you there. And so more data generation is just doing that exam we talked about, checking mental status, right? If the patient has appropriate mental status, can you just ask them, are you thirsty? It might be very revealing just from kind of the initial get-go, and then kind of looking for evidence symptomatic of end organ damage, chest pain, dyspnea, looking for infectious causes, dysuria, doing our exam, looking to see if they have moist mucosal membranes, if they're producing sweat in their axilla, right? All these kind of help us. And you're going to do this quick. You're going to get used to it, and you're going to know things like if they have stigmata of cirrhosis. You're going to quickly look at their medication and trend their vitals as well as their labs. Maybe this patient has been intermittently hypotensive and this isn't new, and this is just their baseline because they're patient with cirrhosis. And then if you feel comfortable with an ultrasound and you still don't know what's going on, that's a good place to go and grab the ultrasound. If the patient is stable, you can leave the bedside to go get an ultrasound. I would encourage you not to leave the bedside on an unstable patient to go grab an ultrasound. You should just be trying things there at the bedside, like giving fluids and giving vasopressors and starting antibiotics. And the most important thing, kind of going back, is looking for clinical evidence of congestion. This is kind of asking, will our patient be safe to receive IV fluids? And so I put this slide to dedicate this, that this is probably one of the most important things that you're looking for when you're at the bedside. All right, so our patient from case 1, our gentleman, he's starting to look pretty rough, and the stat nurse is getting a little irritated with us. So yet again, you know, she kind of asks, hey, what the heck are we going to do here? And I think Brandon kind of raised earlier whether this patient had received fluids or not, and I think that, right, is a good place to start. We didn't see any evidence of volume overload with this patient, so we should proceed forward, and we give a 500 cc bolus of LR, and we do that within 5 minutes, and we see that their blood pressure improves, and then we get our labs back, and we note that this patient's hematocrit returns at 18. So what type of shock was this?
Hypovolemic.
Yeah, hemorrhagic hypovolemic shock. So I think it's important to note that, right, we looked at that delivery oxygen equation. Really the most important thing about that oxygen equation is don't forget about anemia. So we're going to give this patient fluids to get their blood pressure up, but don't forget that the way that we deliver oxygen is through our hemoglobin. So this patient needs a blood transfusion. And for this case, right, you would want to trend the hematocrit afterward to make sure that we're not losing track, because giving fluids and eliminating hypovolemia as the only cause of shock doesn't mean you're done. You still need to follow up on response and figure out what is going on with this patient. Now, this is a very common scenario for the Jerry service. These intramedullary nails kind of cause like bone marrow stunning, and so it's not uncommon for these patients to have worsening anemia a couple days after surgery. So this just all depends on the clinical context, but training the hematocrit would be important. And then this is a patient who has hemorrhagic shock or hypovolemic shock. So the first question we mentioned is what type of shock. You go to the bedside, you try to come up with your initial hypothesis, you test that with a physical exam and interventions, and then you ask yourself, will I hurt this patient if I give them fluids? And there's several ways to do that, and really it kind of comes back down, the gold standard is, hey, you give this patient fluids and do they improve or not? But it's not always the right thing to give patient fluids to test the hypothesis, and there's other ways to do it. For a non-ventilated patient, the passive leg raise is probably the best validated at trying to understand of whether a patient is fluid responsive or not. As we're talking about fluid responsive, I just want to kind of acknowledge that we looked at the equation at the beginning here, and when we were looking at the perfusion pressure equation for the mean arterial pressure, we acknowledge that sometimes you can increase cardiac output, but you don't see improvement in that mean arterial pressure. And so with any of these, really the gold standard is looking with an ultrasound and looking to see how that cardiac output improves. So anything that we do outside of that is just markers or surrogates, and one of the best surrogates is actually arterial line tracing. And so for our patients, for our passive leg raise patients, that's how that was validated. We use, right, blood pressure cuffs most of the time, but we should see a 9% increase in pulse pressure, difference between systolic and diastolic pressure, when we do the passive leg raise. And the passive leg raise is you have your patient sitting up in bed, you lay them flat, and then you lift their legs up to 45 degrees and you measure their blood pressure in 30 seconds after you lift those legs up. And what that's doing is that's providing about a 300 cc, maybe if your patient's bigger, up to a 500 cc fluid bolus. That's the safest way to test for fluid responsiveness in a non-ventilated patient. And then really the benefits diminish supposedly in around 90 seconds, so you have a little time window. Get that blood pressure cycling at 30 seconds and then cycle again. And then that if the patient's positive, you are seeing more than a 9% increase in pulse pressure, that's when you would try a fluid bolus of at least 500 cc's. In ventilated patients, you're looking for pulse pressure variation or respiratory variation greater than 12%. There's other ways to do it. We will kind of address those in a little bit. And then there's just giving IV fluids. So if you could look at cardiac output and you feel comfortable with your ultrasound, which I don't, sometimes people will look at the carotid flow velocity, sometimes they'll look at the left ventricle outflow tract. Those are difficult to do. But giving a bolus would be a minimum of 4 cc's per kg in 5 minutes. And that's usually 300 to 500 cc's, depending on patient size, in 5 minutes. Now, some studies have looked at the smallest fluid bolus from 50 cc's to 100 cc's in 1 minute. It just really all depends. You know, I'm a pretty big fan of the 250 cc bolus until I did this presentation. So I think for myself, I'm going to have to increase to 300 to 500 cc's in 5 minutes. I'm starting to think maybe we should be doing 300 cc's in 3 minutes, because it really seems like you need to be having 100 cc's in a minute or more to really optimize your chance of understanding whether a patient is going to be fluid responsive or not. All right, so this is a PowerPoint. This slide, excuse me, kind of goes back over what I was just mentioning about trying to understand whether we should be looking for fluid responsiveness. And this is why it's so important to go to the bedside, because if you see obvious causes of hypovolemia, if you see dry mucosal membranes, you're just going to give fluids. If you don't have concerns for reduced DF, then you just go forward and give fluids, as we were mentioning with that mini bolus, and then going from there and following up on response. But if that's not true, if there is not obvious hypovolemia, and if you're uncertain, then it's utilizing these testing mechanisms. And really the biggest one is kind of, are the following conditions present, whether they're spontaneously breathing, if they have cardiac arrhythmias, or they have ARDS with low tidal volumes. Because, for example, the respiratory variation of the IVC, or either the pulse pressure variation of the ventilated patients, those were done with 7 to 8 cc's, or I think 8 cc's per kilogram, as far as for tidal volumes. So if you have your patient down on, 6, then you actually have to change their tidal volumes to be able to properly use that test. Then there's things like end expiratory occlusion tests. I've never done that test. That means at the end of expiration, you have to occlude that patient for 12 to 15 seconds, and you're looking for a greater than 5% change in their, as far as for their pulse pressure variation. So that's not, I've never seen that test done. That's something that I saw more throughout my reading. But again, I think that it's going back towards looking at pulse pressure variation, considering passive leg raise if they're any kind of AFib or they're not fully dependent on the ventilator. So if you're having problems though, and you feel comfortable enough to use an ultrasound to look for B lines, I actually think this might be the most or easily approachable way to utilize an ultrasound initially to figure out if it's safe to give your patients fluids. And here the big thing is, hey, is there variation within the IVC? And if there's variation, then you give fluids. And really, for the most part, in a lot of the studies, they looked at, hey, is the IVC less than 2.5, and is the variation more than 50%? And that made patients more likely to respond. But really, I think it's as simple as, is there variation? All right, if there is variation, give fluids. If there's no variation, look for B lines. And oftentimes you'll see these B lines before you hear crackles. And the B line should be bilateral. And I just want to throw that out too, because there is cases where you can get B lines for early pneumonia before you get a frank consolidation when the lung is just starting to become edematous. So the B line should be bilateral, and you'll often see that before you hear that. And just to verbalize what B lines are, it's when you apply your ultrasound probe to the lungs and you see these bright lines. When you have 3 more of those, then that is what we call B lines, and that is suggestive of edema within the lung parenchyma. All right, and then this is a slide that I found from Arnfeld and Lee and Corey, and I thought this was helpful. And I just put this in because for those of you who feel more comfortable with the ultrasound probe, this kind of goes back to, hey, is it distended greater than 2.5 or is it less than 1.5? And then there's different ways to look at whether a patient is intubated or not intubated. And really going back to the prior slide, I just think that this one is really, really helpful when we're just learning how to use an ultrasound probe, is looking to see if there's IVC variation and then looking to see if there are B-lines, and don't overcomplicate it. All right, and which patients should we be careful with regarding fluids? Those are patients with cardiac disease, with liver disease, with kidney disease, are old patients, are very, very old patients, and are very, very young patients. Given that we're internal medicine doctors, we're often not working with the very, very young patients. So really, we're worried about our older patients. And then patients with lung disease, especially those on oxygen therapy. And the reason why is if they do develop pulmonary edema, it's going to cause a considerable amount of mismatch for them and shunting, and their hypoxemia could dramatically worsen, and they may require earlier ventilation if you volume overload your patients with lung disease. All right, so our next case is a 62-year-old woman with history of type 2 diabetes, hypothyroidism, hypertension, acid reflux, chronic lower back pain, and she was admitted with adverse risk AML and is being followed for a course of G-clam. She's on a heparin drip for a PE and has previously diagnosed with pneumonia. She's somnolent and only verbalizes back pain, and we were called to the bedside because she has a heart rate of 72, a blood pressure of 74/45, and is on 2 liters via nasal cannula. We know that she had a normal ejection fraction prior to starting chemotherapy. And unfortunately, we cannot complete a passive leg raise given her size. The maneuver causes worsening back pain, and every time we tried with our nursing colleagues, the patient would become agitated and shake around, and it was unsafe given her size as much as anything else. So we do recheck. Whoops, sorry about that. We know that the point of care glucose is 128, and we know we have a little improvement in blood pressure with a 500 cc bolus. And the stat nurse asked, what do we want to do next? And here's our labs. So what would we want to do next for this patient who had some improvement with a fluid bolus? And those are our labs. And I'll just read out the labs and kind of acknowledge that we've had a worsening leukocytosis from 11 to 13. We see our worsening anemia of the hematocrit going from 36 to 34. We have hyponatremia, which has been stable. We have an acidemia with lower bicarb. We see our creatinine is increased a little bit and now is at 1.8 with a BUN of 65 and her blood sugar is 30. Her lactate was 3 and her troponin was 0.08. What are we thinking about this with this patient? And I'll just say, if someone wants to shout out how you're thinking, I'll just say at the bedside when we're feeling her, she's not warm and she's not cold. The exam is pretty equivocal and she's quite obese, and so we're not really seeing much evidence of volume overload for her.
JP, I don't know if you can see the chat, but there's a bunch of things in there.
Oh, I can't. Let's see if I can.
Here, JP, I'll just call out a few things that people have asked. Someone asked how much O2 is she on, if she has an EKG, and then just some thoughts in infectious workup, concern for sepsis. Also could be a lot of other things, including significant PE with obstructive shock, cardiac ischemia, some suggestions for fluids, antibiotics, cultures, potentially pressors as well.
I think those are all the right thoughts. I would say that, so the ECG on her, she had normal sinus rhythm. She was on 2 liters via nasal cannula and satting at low 90s. And then I think that all the things that were said were correct. This is a patient where you're going to have a broad differential, right? This is undifferentiated shock. This patient already had pneumonia, so you're gonna look to see what antimicrobials she's on, if any, and you're gonna broaden those antimicrobials. You already got some responsiveness to fluids, so you're gonna give additional fluids. And if after giving a liter with this patient, if you're not seeing improvement, then yeah, I agree. Starting early pressors and talking to the ICU is important. And then this patient, you know, could have a worsening PE on a heparin drip. One thing to consider too is bleeding. I mean, there was no obvious source of bleeding at the bedside for her, but that's the other thing to think about for her. And so I kind of mentioned here, consider bleeding, consider infection, consider MI. What else should we consider? And I think you were all right. Being broad is as important as anything. And we have that troponin 0.08, and you're definitely going to trend that. And you may not be able to get a formal TTE overnight, but that's something you're going to want pretty early, as soon as you can in the morning, because this is going to be an undifferentiated patient. Until you find an alternative cause, you need to be broad. And that's just kind of going back to that fantastic algorithm that I put forward by the McGraw company, the educational book company. And so I think everything that was said was correct. And something to think about is these mixed shock states, right? I mean, it doesn't always have to be due to one cause, and this is pretty common. And you just need to consider if exam and workup is equivocal. I mean, consider like sepsis and Takotsuba's cardiomyopathy. Consider a patient who becomes hypovolemic and has an MI as well. There's a lot of ways to kind of end up in this mixed shock state. You can be infected and have poor heart function. So if you're uncertain, start at antimicrobials, obtain infectious workup, trend your labs, start pressors early after you give fluids, be broad in your differential, and involve other colleagues to kind of help you troubleshoot. You don't have to be on your own when you're going through these. All right, it's 9:48. I just want to say that simplified pressors. So starting out with norepinephrine when you don't know what the cause of shock is not the wrong decision. And I just want to throw that out here because I think when we start to learn about pressors, it can be a little bit overwhelming at times, trying to remember, is this alpha, is this beta, what the heck is going on here? But really, norepinephrine in an undifferentiated shock patient is not the wrong choice. We know that for patients with cardiogenic shock, norepinephrine is not the wrong choice. For sepsis, norepinephrine is not the wrong choice. I mean, if you have a patient with cardiogenic shock, is volume overload, cold, clammy, I mean, you're going to likely want to start off with dobutamine, but norepinephrine is also good to add in because that does cause some inotropic effects as well. All right, so what happens after shock progresses? So that patient that we talked about about the G-clam, the one we just went through, she actually ended up having a retroperitoneal hematoma, and that was her cause of shock. And so, you know, sometimes it's really hard, and the only way we ended up figuring out is we brought in the antimicrobials, we tried fluids, we ended up starting pressors, and then once we stabilized her, we were able to get her down to a CT scan. And sometimes that's what you have to do. You just have to stabilize the patient to be able to do your next mode of diagnostic. But what happens if we're not able to deal with it? Oftentimes, these patients will progress to PEA arrest. Unless they have underlying cardiac disease, then they could go into VFib or VF. And that would just because they have like an ischemic foci or some scar that's really sensitive to hypoxemia or hypoxia in the heart. And so oftentimes these are patients who go to PEA arrest. And if that is the case, it's really helpful for you to tell that Code Blue team what you think is going on, what you did going forward. All right, so I want us to do group breakout. We have about 10 more minutes or so, 10 to 25 more minutes. And so I just want to pause and see if there's any questions before we go into our group breakouts. But the hope for the group breakouts is that kind of stimulates some discussion because I've been just like yammering out here for 50 minutes now. So my hope is that you go through the case, that it generates some questions, some things that have not been answered by my rush through shock, and that when we come back together, we could talk through. You know, the other thing I just want to acknowledge is when you go in this break out session is just say hello to one another. And if someone has had a case of shock that was problematic or difficult for them, that would be fine to share with the group too. I just really want to create a space that allows us to stimulate conversation and discussion and kind of turn our lights on. So please engage with one another and let me know what questions come up.
Awesome. So you guys can see I threw in the chat, there's a link to a folder that has some of the case information that JP put together for everyone to review, unless people are going to sort of have conversations within their own group. If you guys would not mind just clicking on that right now before you are sent to your breakout rooms, otherwise it disappears in the chat. And then you guys can feel free in your groups to share your screens, etc. We'll go in the groups until 10 and then come back together, talk for a few minutes, and then there'll still be some time for a break before Ken hops on at 10:15. So Javel, if we want to send everyone to their groups. There we go.
John must have left.
I was going to say, is John still here? I saw him earlier.
Left. Yeah.
Okay, great.
All right.
Great. Yeah,
Cool.
I think JP initially planned to talk until, well, I don't know. Are you still recording this part?
Yes. Let me pause.
Kind of going through it. This was a patient who had an equivocal exam when we were at the bedside, and you'll notice that the transfer summary didn't really offer us much. Our data kind of didn't tell us one way or the other. The EKG was concerning because there was some ST elevations in V3 and V4, but it was kind of at that 2 millimeter cutoff. Though in a patient who's decompensating, that is concerning. And so for this case, this patient actually ended up going to the cath lab. A code STEMI was called, ended up having clean coronaries. This was a patient who had Takotsubo's cardiomyopathy, was likely associated with worsening sepsis. So this is a mixed shock state, and this is not something that is uncommon for us to see. So it's something to consider. And so so this patient would have been someone I would have been reluctant to give fluids to because they had those bibasilar crackles. And this is a patient who you would talk to cards, and cards would talk to their attending, and then you would go through as they did. This is a patient that required some pressors. What everyone will see is that I changed a few things. This patient was actually on broad spectrum antibiotics and they decompensated, but I changed the case so that there was unison. So the right thing would be repeating infectious workup, broadening your antimicrobials, and then progressing it to evaluate the heart. What questions popped up from that case? All right, so if we have no questions, I just quickly am going to share my screen again. All right. Just quickly, our objectives again was that shock is an acute circulatory failure threatening multiple organ systems and demands prompt diagnosis and urgent resuscitation. And there's three main types of shock that we kind of lumped in this presentation: hypovolemic, cardiogenic, and distributive. Remember, pump pipe tanks. And that shock should be managed by quickly identifying and treating reversible causes. The real question should be like, is this patient going to be harmed with fluids? And then following up on our initial interventions to make sure that they're appropriate. And then using bedside ultrasound if you're comfortable, and keep it simple. Look for B lines. Look to see if the IVC is really dilated more than 2.5 centimeters, or if there's any collapsibility with respirations. That's the extent of my talk on shock. We can leave a few moments for any questions, concerns, general feedback.
Awesome. JP, you are probably now able to see the chat, but a lot of thank you and a lot of praise. Great. Why don't we take a 10-minute break? So back at 10:15, everybody, for Ken's house staff meeting. Thanks again, JP.